And if you're just joining us, hello, welcome to our STI Clinical Update webinar. I know folks are still joining from the waiting room, but we're going to be talking about all things Mpox today. So I'll go ahead and get started and go over a few introductory things as some folks are still coming in. But today's webinar is entitled Mpox Clinical Update, What's New, What to Suspect, What to Do. And this is all about recognition and prevention. And we're very fortunate to have our two speakers, Drs. Eric Tang and Jason Zucker, who are both experts in this area. My name's Kelly. My last name's Johnson. I'm the medical director for the California Prevention Training Center at the University of California, San Francisco. Today's webinar is a collaboration between our group, the California Prevention Training Center, and the California Department of Public Health. So I'm going to tell you just a little bit about the California Prevention Training Center to start. So we are a multidisciplinary training and capacity building assistance center. And our STI clinical training, as you may know, is sponsored by the CDC, and we're a member of a larger national network of other STD prevention training centers. We do many things, but that includes providing virtual and in-person trainings, technical assistance, and clinical consultations, as well as clinical tools. It's all about complex STI issues in patient care. If you want to learn more about us or the network of which we are a part, you can check out the links on this slide. I do want to tell you about one of our resources, which is the STD Clinical Consultation Network. You can see the website there. This is an online portal where you can submit your patient care complex questions about STIs, and one of our subject matters will respond to you in 1 to 5 days, whatever you prefer, and we can do that by phone, by email, or even by text. Now on to some information about today's event. So this is our financial disclosure stating that we have nothing to disclose. Here's our accessibility disclaimer saying that these materials are provided for informational purposes only, and they may not fully meet the requirements of the ADA or Section 508. So if you'd like the content in a different format, you can contact us at the email address, that you see on the slide here. Here's our CME disclosure, which states that today's event is offered at 1.25 CME units at no cost. But there are some things you need to do to earn those CMEs. So you do have to have registered on the NNPTC site for this webinar by June 1st at 3 p.m. Pacific. So please note that registration has now closed. You also need to attend the webinar live and in full. We'll record your attendance as you sign in, so you don't have to do anything to get your attendance recorded, but you do have to stay for the event. And we are unable to issue CME if you're attending just a part of today's webinar or if you're watching any available recording after the fact. Third and lastly, you do need to complete a post-course survey evaluation, and the deadline for that is June 10th. That post-course survey evaluation will be sent out about 24 hours after the webinar. You'll get an email. It will come from training@nnptc.org. It will come to the same email address that you used to register for today's event. Just make sure you receive that email by adding it to your safe and trusted senders list, and monitor your spam and junk folders if you don't see it. If you do meet the CME requirements, you'll receive notification by June 15th. You'll get another email. It'll have a claim link and instructions about how to get your certificate. This CME notification will come from our email address, captc@ucsf.edu, again to that same email address that you used when you registered for this webinar. And please add us as well to your safe and trusted senders list to make sure you get your CME notification. The other thing we get a lot of questions about is our post-course materials. So you will get a post-course materials notification email with a link to the webinar recording, a slide handout, some reminders about CME, and anything else we have available. This will all come to you in email about 2 weeks after today. You don't need to do anything. These materials will just come to you. And again, it will come from this email address that you see on the slide. Now, as you probably know how Zoom works, I'm just going to go over it briefly. A couple quick housekeeping notes for today. The Q&A will be turned on during the webinar for the attendees, but the microphone, video, and chat will be turned off. If you want to use the Q&A, you just click on that little icon you see on this slide here, open the Q&A chat, type in your question, and click send. As attendees, you can submit questions up until the last 2 minutes of the Q&A section. And your questions will either be answered by me in the chat, or I may save them and present them to our speakers at the end of their talks to have your questions answered live. If you have questions about today's events or anything else, you can contact our program manager, Elizabeth Olson. Her email address is there on this slide. And without further ado, I'm very pleased to welcome our two speakers. I'd first like to introduce Dr. Eric Tang, who's a public health medical officer in the Office of Sexually Transmitted Infections and Hepatitis C virus at the California Department of Public Health. He is double board certified in internal medicine and preventative medicine. And in his role at the California DPH, he is actually the chief of the Medical and Scientific Affairs section. And he's directed several CDC-funded initiatives. You can read more about them on the slide. But for the purpose of today's talk, he serves as the Mpox lead for the California DPH, where he plays a bunch of key roles in detecting and responding to outbreaks, as well as our first clade 1 cases in the state. I would also very pleased to introduce Dr. Jason Zucker. Dr. Zucker is an assistant professor of medicine and pediatrics at Columbia University Irvine Medical Center. He's board certified in two things as well, adult and pediatric infectious diseases. He provides sexual health care, working at a clinic in Columbia. His focus is on HIV, STIs, including Mpox. And I would say for the purpose of today, he's truly become a national Mpox expert. So he's been deeply involved in Mpox research and policy at the national level. He was deeply involved in a study called STOMP that you may have heard of, and you'll hear more about that today. He has published in New England Journal of Medicine on Mpox and has led multiple CDC-funded Mpox studies, which again, you'll be hearing more about in just a moment. And I will now turn it over to Dr. Tang to kick us off. Thank you all for being here.
Thank you, Dr. Johnson, for that introduction. We can go to the next slide, and I do not have any financial disclosures. So I'll just remind people of our learning objectives today. So by the end of the webinar, we hope that you'll be able to describe the latest epidemiological trends and key developments in Mpox, both in the US and globally, with a particular focus on the emergence and clinical implications of clade 1 Mpox. 2, to integrate the most recent CDPH Mpox vaccine and prevention recommendations to routine clinical practice. And 3, identify and diagnose Mpox and when to spread clade 1, and when to suspect clade 1 Mpox, ensuring prompt and effective management, which will primarily be covered by Dr. Zucker. Next slide. So I'll be kicking it off with Mpox epidemiology. Next slide. So first, to begin with some background, Mpox is an infection caused by the monkeypox virus. It is part of the orthopox virus genus, along with variola, virus that causes smallpox. And there are two types of clades of Mpox, clade 1 and clade 2, each with their own subclades, 1A, 1B, 2A, and 2B. The map on the right indicates that the areas where each clade was endemic prior to 2022, clade 1 in Central Africa and clade 2 originally in West Africa. Clade 2, and specifically clade 2B Mpox, was what was responsible for the global outbreak and public health emergency that started in 2022. And to date, it has caused more than 100,000 cases in 122 total countries, including 115 countries where Mpox was not previously reported. Cases of clade 2B Mpox continue to spread at low levels worldwide and in California. In late 2023, clade 1B emerged and began to spread in the Democratic Republic of the Congo, or DRC, and then neighboring countries in Central and Eastern Africa. Next slide. So historically, clade 1 Mpox was thought to have a much higher case fatality rate than clade 2 Mpox, with reported case fatality rates of 3 to 11% in endemic areas. However, data from recent outbreaks suggest that the case fatality rate for both clades is much lower, especially when optimal supportive care is provided, and studies are ongoing to study this more closely. Risk factors, affected populations, locations of sustained transmission can differ between clades and even subclades. Clade 1A and 2A are primarily spread by contact with infected live or dead wild animals and is not causing significant spread beyond Western Central Africa at this time. So for the purposes of this presentation, I will not be focusing on these subclades today, but this summary table compares clade 2b with clade 1b. Focusing first on clade 2b on the right, which is what people are most familiar with, this subclade was endemic to West Africa, and as I mentioned before, led to the global outbreak since 2022. This clade 2b outbreak was primarily affecting adults, particularly men who have sex with men, or MSM, in the global outbreak. And in comparison to clade 1b, clade 1b was newly identified as a subclade in late 2023 in the Democratic Republic of the Congo, and then spread through sustained human-to-human contact, primarily through sex workers and their contacts, although more recently among MSM, which I'll go into a little bit later. Subsequent spread of clade 1b has been identified through day-to-day household contact as well. Transmission for both clades is primarily through close skin-to-skin contact, and both have efficiently spread through sexual networks through intimate contact. Transmission via fomites is also possible, often within households, and can also be spread from mother to fetus during pregnancy. Data from the global clade 2b outbreak indicate that the mortality rate of clade 2b is less than 0.1%, and for clade 1b appears to be less than 0.5%. Still low, but perhaps higher than clade 2b. Of note, no mortality has been seen with travel-associated cases in high-income countries, but data is limited. Next slide. So clade 1b has continued to spread person to person globally. Initially in 2024 from people who had traveled to Central or Eastern Africa, but we are now seeing travel-associated cases originating outside of Africa, and most commonly in Europe. Since fall 2025, several countries in Western Europe have reported clade 1-Mpox cases not associated with international travel, many which are associated with but not limited to sexual networks of MSM. To date, there are over 300 clade 1b cases that have been reported in high-income countries, but fortunately no deaths have been reported in these countries. The World Health Organization, or WHO, indicates on this map in orange countries in which they classify as having ongoing community transmission, while countries in yellow are those with recent travel-associated cases in the past 6 weeks. Next slide. The data from the WHO is displayed here, which is updated every 2 weeks, and they, as I mentioned, classify a number of countries that have community transmission of clade 1, which is shown on the table on the left. And this includes Madagascar, where there is currently the second largest clade 1b outbreak, as well as many countries in Europe, including Spain, Germany, Switzerland, and Portugal, but also countries in Asia and South America, including Thailand and Colombia. The WHO also reports imported clade 1b cases, as seen on the table on the right. And since the beginning of April of this year, the WHO has reported adult males who have traveled to countries categorized as having community transmission, but also to countries that are not listed here, which may suggest undetected transmission in these countries with suboptimal testing or surveillance. Next slide. So zooming into data from the European Union, or EU, we see on the map on the right that many EU countries have multiple clade 1 cases, with higher numbers in Spain and Germany, where there have been published outbreaks among MSM without any travel history, which have been attributed to a locally acquired transmission of clade 1-Mpox. Of note, the United Kingdom also has had approximately 50 clade 1-Mpox cases in the past year. The vast majority that have been in England, although this is not reflected on the map because they are not part of the EU. Interestingly, looking at total EU Mpox cases in the graph on the left, you can start to see a greater proportion of cases over time that have been determined to be clade 1 versus clade 2, particularly as we continue into 2026. For cases where sexual behavior information was available, greater than 90% of both clade 1 and clade 2 cases in the EU were among MSM, and about a quarter of them were 2-dose vaccinated. The EU, which has substantially more clade 1 cases than the US, also gives us a glimpse of potential differences in severity in clade. Next slide. Or next slide. I think there should be the animation. There you go. About 13% of clade 1 cases were hospitalized compared to 8% that were hospitalized for clade 2 cases. And while this is statistically significant, the European CDC has reported that several of the initial clade 1 cases were hospitalized at the beginning of the outbreak, not for severity, but more for isolation and concern for clade 1. So the estimate may be biased, and the difference in percent hospitalized between the two clades appear to be narrowing over time. In California, we have also seen a relatively high hospitalization rate of people with clade 1 Mpox compared to clade 2, although numbers are small, and all were either immunocompromised, unvaccinated, or both. Next slide. As for clade 1 Mpox in the US and California, the California Department of Public Health, or CDPH, confirmed the first case of clade 1 Mpox in the US in San Mateo County in November 2024, in a person who had traveled to an Eastern African country experiencing a clade 1 outbreak. Just April of this year, San Francisco also reported their first case of clade 1 Mpox, which was the 7th confirmed clade 1 Mpox case in California. It is notable that the San Francisco patient was unvaccinated and had not traveled during his incubation period, but he was a close contact to an international traveler who went to an area where there was a clade 1 outbreak. He was hospitalized but improved and later discharged to isolate at home, and the patient has since recovered, and no additional forward transmission of clade 1 Mpox was identified from that case investigation. In the US, sporadic travel associated cases of clade 1 Mpox continue to be reported, and as of yesterday, the CDC has reported 23 clade 1 Mpox cases. From November 2024 to February 2026, which is a period of 16 months, there were only 11 cases reported, but since March of this year, which is just over 3 months, 12 cases were reported. So the majority of clade 1 cases have been reported in the past, in the US have been reported in the past 3 months. And all have traveled, all the 23 cases have traveled to areas associated with the outbreak, initially to Central or Eastern Africa early on, but more recently to parts of Western Europe, where I've mentioned new outbreaks have been reported, or they were linked to people who had traveled to those areas. Next slide. So in this slide, I want to walk through the timeline of how both clade 2b and clade 1b Mpox have spread globally and why this matters for our current situation. Starting with clade 2b, the clade was first identified in May 2022 in the UK in a traveler returning from West Africa. And shortly after, additional cases emerged among MSM in the UK and other countries, followed by clusters in Canada and then rapid expansion into the US and globally. This ultimately led to a large multi-country outbreak that continued through 2022 and beyond. Shifting to clade 1b, this subclade was initially emerged and led to the outbreak in Central Africa in 2023 and later spread into Eastern Africa, primarily through heterosexual networks. The first US California case, as I mentioned, was detected in November 2024 in a traveler returning from Eastern Africa. And since then, we've seen several cases and clusters in Europe among MSM who have more recently had no travel history, indicating growing community transmission in that continent. And now in the US, we're seeing a rapid acceleration of clade 1 introduction since March 2026, mostly from travel to Europe. So as we look ahead, LGBTQ plus Pride Month just started yesterday, and the season has really kicked off, bringing large events that have previously been linked to Mpox in previous years. And with the World Cup starting next week, with games in Santa Clara County and Los Angeles County, we expect a rise in international and summer travel, and we anticipate that there are going to be many more clade 1 Mpox introductions in both the US and California. And this just underscores why it's important to stay vigilant and why vaccination is really important, as well as early recognition right now to keep clade 1 contained and preventing it from spreading in California and the US. Next slide. For my last epi slide, I will move into Mpox in California. So on the left, you'll see a heat map on Mpox cases in the state over the past year. We see cases throughout the state, although there are highest numbers of cases occurring in the San Francisco Bay Area, as well as in Southern California. in particular in Los Angeles, San Diego, Riverside, and Orange counties. Of note, compared to 2024 and 2025, we are seeing a higher number of Mpox cases, and specifically Mpox clade 2 cases in 2026. So far this year, the weekly average number of cases have more than doubled, about 14.5 cases per week in January through March, compared to around 6 per week in 2024 and just over 3 per week in 2025 during the same period. The demographic patterns overall remain similar, with the vast majority of cases occurring among men, and about 98% who are men, with most identifying as gay or bisexual when we have sexual behavior information. However, compared to the first quarter of 2025, we are seeing higher proportion of cases among people who are identified as heterosexual, people identified as Hispanic or part of the Latinx communities, as well as more cases among women. We've also seen a higher proportion of unvaccinated individuals. And importantly, I wanted to share that we identified reinfections as well. From May 2022 to May 2024, we will confirm that there was at least 0.14% of our cases, or 11 cases, that were reinfections, and they tended to be more mild than the initial infection, and that's more likely to be a significant underestimate of the real rate of reinfection, as fewer people may present to care, or clinicians may not recognize the symptoms as reinfection and under test. But the main point here is that you should still consider Mpox in patients with previous infection if they have clinically compatible symptoms, which Dr. Zucker will go over soon. Next slide. Next, I'm going to go over vaccination. Next slide. So Diagnose is the only Mpox vaccine that is currently commercially available in the US and FDA approved for the prevention of Mpox. It is a third-generation vaccine based off live attenuated orthopox virus vaccine, modified vaccinia Ankara, and it remains our primary tool for protection against both clade 1 and clade 2 Mpox. After 2 doses, observational studies have shown the vaccine is up to 89% effective in preventing infection. While infections can still occur after receiving 2 doses, vaccinated individuals tend to have much milder disease and are less likely to require hospitalization. The vaccine series consists of 2 doses given at least 28 days apart. If someone received only 1 dose and it's been more than 28 days, they do not need to restart the series, and the second dose can be administered right away. Diagnose can also be used as post-exposure prophylaxis, or PEP. And ideally, it's given as soon as possible after an Mpox exposure, within 4 days to prevent Mpox entirely, and between 4 to 14 days to reduce symptom severity. Overall, vaccination remains one of our most important strategies for reducing both individual risk and community spread. Next slide. So based off our current outbreak data, and to simplify assessment and improve community vaccination coverage among those at increased risk of exposure, CDPH provides more comprehensive Mpox vaccination recommendations than either the CDC or the Advisory Committee of Immunization Practices, or ACIP, and we recommend vaccination for anyone who may be at increased risk for Mpox exposure. This includes gay, bisexual, and other men or sex with men, transgender, non-binary, and gender-diverse individuals, and all people who have HIV or who are taking or eligible for HIV PrEP or doxy-PEP. Ensuring all your patients with HIV are fully vaccinated for Mpox is important because this is the group that is at highest risk for severe disease, hospitalization, and death, particularly if they have a low CD4 count. Vaccination is also recommended for anyone who has been exposed to a person with Mpox within the last 14 days as part of PEP, as I mentioned before. And we've expanded our vaccine travel recommendations to include people planning any international travel, especially to regions where clade 1 Mpox is spreading, if they anticipate sexual or intimate contact while traveling. And as noted earlier, areas of the world in which clade 1 Mpox is spreading is expanding, and vaccination can help prevent infection and spread when travelers return home. Similarly, individuals planning to attend commercial sex venues such as sex clubs or bathhouses are encouraged to get vaccinated, as we have seen cases associated with attendance at these venues. We also recommend vaccination for anyone who has a sex partner with any of these risks, as well as for anyone who requests vaccination against Mpox, regardless of whether they choose to disclose any of these specific risk factors. This approach helps to reduce barriers, since some risk factors may feel stigmatizing or uncomfortable to share with their healthcare provider, yet vaccination may still benefit them and strengthen broader community transmission. Next slide. So in this slide, I want to highlight that we strongly recommend Mpox vaccination for at-risk people who are immunocompromised, including, again, all people who are living with HIV and who are at highest risk of severe disease. And I emphasizing this because I want everyone to hear that Jynneos vaccine is safe for people with weakened immune systems or for those taking immunosuppressive medications. Unfortunately, we see multiple cases of people with Mpox who were previously not offered the vaccine because they were told that being immunocompromised was a contraindication, which is not true. And these people are the people who would most benefit from vaccination because they are the highest risk for severe disease and hospitalization, which Jynneos has been shown to prevent. It's also important to note that the vaccine is not contraindicated during pregnancy or while breastfeeding or chest feeding. And note vaccination for people who have already been diagnosed with Mpox. Um, it's not recommended for people who have been previously vaccinated with Mpox because natural infection is thought to provide robust immune protection, and reinfection appears to be quite rare. And at this time, booster doses are also not recommended for the general public as it's unclear if it will truly lead to any clinical benefit. And despite our recommendations, CDC's latest estimate was that only about 68% of at-risk Californians have received at least one dose of vaccine, and just 43% have completed the full two-dose series. Increasingly, this coverage is critical for preventing severe disease, reducing transmission, as well as protecting communities from outbreaks, especially those with historically lower access to care. Next slide. So here's a CDC modeling study last updated in November 2024 that assessed the potential spread of clade 1 Mpox and the risk of clade 1 Mpox outbreak in 50 U.S. counties if clade 1 Mpox was introduced into the community. It explored impacts of population immunity and transmissibility on sexual transmission of Mpox among gay, bisexual, and other MSM. The modeling accounted for varying levels of transmissibility, county-specific population level immunity from previous infection, estimated undiagnosed infections, and receipt of 1 or 2 doses of Jynneos vaccine. And the California counties they included in their model were San Francisco, Los Angeles, Alameda, San Diego, Riverside, Sacramento, Orange, and San Bernardino. So depending on the increase in transmissibility of clade 1, which so far has not been shown to be more transmissible than clade 2, the greater population level immunity per county leads to lower chance of prolonged or large outbreaks. Therefore, using the row highlighted or the column highlighted in yellow as an example, assuming that there is no difference in transmissibility between clade 1 and clade 2, in San Francisco, which has a high level of estimated population immunity, mostly due to overall high vaccination rates, the model predicts only 15 cases of clade 1 Mpox would be diagnosed if clade 1 is introduced into the population. However, with San Bernardino County, which has a much lower estimated population level of immunity, 174 cases of clade 1 Mpox are estimated to be diagnosed. Therefore, while vaccination is important at the individual level, it's also particularly important at a population level to prevent large outbreaks in the community when we expect to have continued introductions of clade 1 Mpox this summer. Next slide. All right, and finally, my last slide before I hand it off to Dr. Zucker, I wanted to highlight several strategies to improve Mpox vaccination coverage across California. And while ideally we want all providers to stock and administer Jynneos themselves, we understand that there are some barriers in doing this. However, patients can easily find vaccination sites using the Mpox vaccine locator that has been created by Bavarian Nordic, the manufacturer of Jynneos. And although it may not be fully comprehensive, patients should call and confirm whether these locations can offer them the vaccine. Jynneos is widely covered by insurance companies, including Medi-Cal and most private insurance plans, thanks to Assembly Bill 144. State-regulated health insurance plans are required to cover the Mpox vaccine as recommended by CDPH. The vaccine is also available at major pharmacy chains like CVS and Walgreens, where no prescription is needed, and appointments can be made online, although patients should call the store to ensure Jynneos is in stock, as the appointment schedule online appointment schedule does not sync to real-time inventory. And they should confirm that they can take their insurance and that their insurance covers the vaccine. If you as a provider cannot offer the vaccine on site, perhaps you can partner with a pharmacy nearby that you can refer patients to. We also encourage integrating Mpox vaccination into routine clinical care, particularly when you're offering other sexual health services. So that might mean offering Mpox vaccine during visits for HIV or STI testing or diagnosis, or as a part of HIV care, or when providing HIV PrEP, DoxyPEP, family planning, contraception, or even other vaccination visits. And discussing these services together will makes Mpox actually more accessible and increases uptake, especially among those already engaged in sexual health care. And lastly, I just wanted to call it an upcoming opportunity to learn more about integrating the Mpox vaccine into existing health programs. It's a webinar that's happening in 2 days from now at noon, hosted by the National Coalition of STI Directors, and includes former CDC Director of the National Center for Immunization and Respiratory Diseases, Dr. Dimitri Daskalakis, who was also the Deputy Coordinator of the White House's Mpox response in 2022. And I'm going to try to put that information in the chat so people can register if they want. But overall, really the goal here is to meet people where they're at and where they're receiving care, and trying to reduce barriers and proactively offer vaccine to those who would benefit most. So we can go to the next slide, and which will then actually hand it off to Dr. Zucker, who will be covering clinical recognition, diagnosis management, and treatment of Mpox.
So we're going to talk about the presentation and clinical presentation of Mpox, starting with the classic presentation, or what you would have expected to see if you read a book about Mpox. After the incubation period of 2 to 21 days, Mpox classically starts with a viral prodrome similar to many illnesses. This can include fevers, chills, headaches, malaise, myalgias, and lymphadenopathy. And so it really can look like a lot of different things. After the prodrome, patients usually develop a rash. The rash classically starts on the face and spreads to the extremities, including the palms and soles, and progresses through several synchronized stages that can be extremely painful, lasting up to 4 weeks. The rash usually occurs before day 5 and most commonly on day 3. And you can see here how it goes from macules to papules to vesicles to pustules to scabs, and finally and eventually reepithelialization. With the textbook picture established, it's important that we think about the real challenge that we see, and that's that we have a large differential for Mpox these days. Mpox can look like other genital lesions like HSV, primary and secondary syphilis, molluscum we get phone calls about all the time, LGV, chancroid granuloma inguinale. And it can also look like non-infectious causes, things like autoimmune diseases, hidradenitis, drug-induced trauma, and others. The exanthem I mentioned before with the diffuse rash can look like a lot of things as well. Secondary syphilis. You can get vesicles all over the body that can look like primary varicella, disseminated varicella, or disseminated HSV. And again, molluscum, disseminated gonorrhea, scabies, hand, foot, and mouth disease, as well as non-infectious mimickers like pityriasis rosacea, autoimmune disease, and drug-induced rashes. And I will say that over the course of 2022, when we were seeing a lot of Mpox cases, our pre-test probability was high, and we were really good at making the diagnosis. Since that time, as cases have gone down, we have been fooled many times, sometimes thinking things were Mpox and finding other causes, and other times thinking things were not Mpox and finding that in fact it was Mpox. And so we really need to have a high index of suspicion when we're thinking about Mpox. This is a visual differential diagnosis of Mpox. It's available on the California PTC website. I'm not going to go through it in great detail here, but it's a really nice guide, sort of showing some of the common mimickers with images. What I want to talk about today is why Mpox requires such a high index of suspicion. And that's because it can present in so many different ways. So it can present with a classic rash, but actually what you see in this picture is that during 2022, we learned that it didn't always have to be synchronous. In this picture, you can see that we have asynchronous lesions, so lesions in different stages, which can occur in Mpox as well. We saw high rates in 2022 of genital and anal lesions, again, related to the sexual associated nature of this disease. People were getting it on their genitals and on their rectum. We saw significant amounts of proctitis. Up to 30 to 40% of people could present with proctitis or severe rectal pain. People were presenting with urethritis, things that we would think are classic STIs like gonorrhea, chlamydia, and others, but they actually had lesions, and you can see a lesion right here. I don't know if you can see my point, but a lesion right there of Mpox, so that every time they urinated, it caused intense pain. Again, because of the sexually associated nature, we saw pharyngitis, so people with oral lesions as well. Ocular and eye disease was common, particularly from people auto-inoculating their eyes after touching a lesion and then touching their eyes. Lymphadenopathy could occasionally be a presenting symptom. In fact, the patient in this picture came in and described it was sort of waddling and described it like walking with a fanny pack because he had so much inguinal lymphadenopathy from his Mpox infection. The other thing is because we're seeing a lot of genital and anal lesions. Those are areas that are very hard to keep fully clean. And since we're getting skin breakdown from Mpox, we're getting bacterial superinfections as well. So all of these things could look like other things, but are all from Mpox. There's a couple I do want to make sure I highlight today. And the first is the xanthamin Mpox. These were all patients who were diagnosed with Mpox that presented with rashes that would have been really easy to attribute to viral illness, drug-induced rash, or other things. But these were all due to Mpox. And so you really need to look carefully to see that these patients do have a small number of Mpox lesions in different parts of their bodies. The next thing, as I mentioned earlier, were oral lesions. Again, from oral sex, people can acquire Mpox on their tongue, on their lips, and in their throat. And you can see all those types of lesions here. What's really interesting is this second picture here was a patient with Mpox who the only lesion he had was actually this single lesion on his tongue. And so he actually got admitted to the hospital because he was immunocompromised and they were concerned it could be fungal or something else. And it turned out to be a single Mpox lesion. I will say that over the course of several days, he then developed lesions over the rest of his body. But his initial lesion, the only one he had for 2 or 3 days, was actually this tongue lesion. Again, you can have it on the lips and the throat as well. And then finally, the genital and anal lesions that were very common during the 2022 outbreak and still ongoing today. One thing I want to highlight is the fact that we were talking a bit about clade 1b. The presentation of clade 1b does not necessarily differ from that of clade 2b at all. Patients are still presenting with lesions. Patients are still presenting with genital, anal lesions, pharyngeal lesions, and the lesions don't have to look any more severe or more significant than what we're seeing in the clade 2b outbreak. When it comes to severity, there's two things I like to highlight. The first is that the severity of clade 2b is very low when it comes to mortality. We'll talk a little bit about morbidity in a minute, but when it comes to mortality, it was very low. As of about a year ago, the mortality was about 0.18%, and almost all of those deaths occurred in immunocompromised individuals, really highlighting that for immunocompetent individuals, there was not really a significant risk of mortality. And again, we'll talk about morbidity in a second. We talk a lot about clade 1 in the DRC, which had been previously observed to be more transmissible and to cause more severe infections than clade 2. And I think the jury's still a little bit out on that. One thing you could see from this chart is that as the number of Mpox cases rose, the case fatality rate actually decreased. And that's because as we did a better job of making diagnoses of Mpox and confirming that things were Mpox and not alternative diagnoses, the case fatality rate actually decreased. And so if there is a gap between clade 1 and clade 2, it's much smaller than we initially thought. Now, when I say the mortality of Mpox is low, I don't want to dismiss how significant a disease this can be, especially for people who are immunocompromised. And during the course of this outbreak, that was in large part people with advanced HIV infection, particularly with low CD4 counts. This was a global case series put together in part by Chloe Orkin that really demonstrated that as CD4 counts fall, the spectrum and frequency of complications rise dramatically. Patients with CD4 counts below 100, which are the orange lines, were far more likely to experience dermatologic, respiratory, gastrointestinal, rectal, and systemic complications than those who had CD4 counts 100 to 200, which are the purple lines, and those with 200 to 300, the blue lines, and 300 to 350, the green lines. So Mpox in people with advanced HIV is not just another illness. It really can progress to severe multisystem disease and can be really significant with high mortality rates. Beyond HIV, we have seen severe outcomes in other immunocompromised populations, including individuals status post organ transplants, a couple of people with renal transplants who had negative, very poor outcomes, and including at least one death after Mpox acquisition. One of the reasons for this is actually seen in this Mpox pathology assessment. Patients with advanced Mpox get these significant necrotic lesions on their skin and can have such significant lesions, it's almost like a severe burn. When we looked at these samples at NIH and CDC, we found that prolonged Mpox in people with advanced HIV may be due to ongoing Mpox replication, which really warrants aggressive medical countermeasures and immune optimization. So when we took skin biopsies from people who had Mpox for 6 to 9 months, they still had aggressive amounts of ongoing viral replication in their skin, which explained why these necrotic lesions were happening and why they continued to have such advanced disease. The second thing I want to show you is a pathology study that shows what severe Mpox can do to immunocompromised people as well. This was a study that looked at the autopsies of people who passed away from Mpox who were immunocompromised and found extensive viral infection of tissues and viremic dissemination. So really you can see that they can have invasion of a variety of different organs, which can lead to the mortality we see in advanced Mpox. So again, taken together, these two slides really reinforce that severe Mpox is not a mild skin infection. It's really a disseminated viral disease. It can have ongoing replication in the skin and ongoing replication in a variety of organs, which really needs aggressive treatment whenever possible. And we'll talk about how to do that in a little bit. In addition to people who are immunocompromised, I also want to talk about a couple other populations that are really notable. Mpox in pediatrics. The data from Africa really suggested that pediatric patients had worse outcomes from Mpox. And at least in the 2022 outbreak, that's not what we saw. This outbreak has had much more reassuring outcomes. Data indicated that hospitalization occurred only in about 11% of patients. And most importantly, there were no deaths reported across age groups. So this is really reassuring for the few cases we do see in pediatric patients that we shouldn't necessarily expect worse outcomes. The second group I want to highlight are people assigned female at birth or women. Although the 2022 outbreak was concentrated primarily among gay, bisexual, and other men who have sex with men, women still could be affected. This was 136 cases in women and non-binary individuals across 15 countries. What's important to know is they had very similar risk factors to the rest of the people who acquired Mpox. 89% reported sexual contact, and more than half had genital lesions. And so this is just a reminder that we can't forget about screening women when they come in with lesions that could be Mpox. We also want to screen them as well. In addition to screening women, we also want to think about this in the case of pregnancy. Pregnancy has historically been a high-risk setting for orthopox virus infections, and it does seem like Mpox follows that pattern. Prior to 2022, there were really only a handful of lab-confirmed cases in the literature, but the outcomes were concerning. Out of 5 cases, 3 pregnancies resulted in fetal loss, with Mpox virus identified in fetal tissue and placenta. And we know that smallpox, the related virus, is known to be associated with more severe illness in pregnancy for the pregnant person. Some data we have from this outbreak. This study described 26 cases of Mpox in pregnant or recently pregnant women during the US clade 2 outbreak. The outcomes were overall reassuring with 19 live births and 3 preterm, but there were 4 pregnancy losses, the majority in the first trimester. 14 received treatment that, again, we'll talk about treatment later. And it does seem like clade 2 may be less severe than clade 1 in pregnancy, but transmission to neonates remains possible. And this was another systematic review that actually looked at 33 cases and found even higher rates of adverse outcomes, 9% of miscarriages and 6% stillbirths, with 4 intrauterine deaths overall, as well as multiple pregnancy complications, and vertical transmission confirmed in one of the cases where the placenta and fetal tissue were both PCR positive. There may be clade differences here. Clade 2 has generally had a mild maternal course during the course of this outbreak, while clade 1 has higher rates of fetal loss and severe outcomes. But again, it's a little bit unclear since these are different populations, how access to care as well as other aspects of the population play into that. It is important, though, that we recognize that Mpox in pregnancy does carry significant fetal risks, and we work to prevent it in pregnant people. As a reminder, the Jynneos vaccine that Dr. Tai mentioned earlier is safe in pregnancy. While it's a live vaccine, it's a non-replicating vaccine that can be given in pregnancy. And so if people are vulnerable to Mpox during pregnancy, they should be vaccinated. We talk a lot about the acute illness of Mpox, but recovery is not really where the story ends. The Life After Mpox study, or LAMP study, which was a CDC-funded study that I participated in, followed patients to 10 to 18 months after their infection. And we found that more than half, about 58%, had at least one persistent sequelae affecting appearance or function 10 to 18 months after their acute Mpox infection. The groin and pelvis were the most common sites, about a third, upper extremities, and the penis. And 13% reported real functional impairment, mostly anal, rectal, or urinary dysfunction, even a year out. So this is important to remember that while Mpox mortality may be low in immunocompetent individuals, there still is significant potential for morbidity. And not just physical morbidity, but also psychosocial as well. Compared to individuals without Mpox, those with prior infection were more than twice as likely to report depression or anhedonia. Nearly half described ongoing challenges in their social, sexual, or work lives. Stigma really played a major role, even a year out. Almost a third said they felt hurt by how others reacted to their diagnosis. About 22% were hesitant, felt that people were hesitant to be around them even months later. And 18% reported losing a job or income because of their Mpox infection. So again, the recovery from Mpox is not just physical, it's also social and mental. And so we need to do everything we can to prevent Mpox infections through vaccination. This data was also supported by a study in Belgium that I didn't cite here in the interest of time that showed very similar findings. When it comes to clinical presentation, I do want to highlight that Mpox can definitely be more subtle post-vaccination. Post-vaccination or reinfection, again, we just see less reinfections. Patients have less severe disease. The lesions may not progress through the full classic stages. They have fewer confluent lesions. Many patients come in with a single or fewer lesions. Diminished mucosal involvement, where the genital ulcer may be the only finding. Painless doesn't rule out Mpox. They have reduced analgesia requirements and fewer admissions. These patients are often seen outpatient, not necessarily in the hospital. It's a great reminder that vaccination history does not rule out Mpox, really have a low threshold to test. And I'll tell you that in our clinical setting, we've seen many patients who come in for routine sexual health visits. They're taking HIV prevention medications. They're coming in for quarterly testing. And they're like, oh, while I'm here, I have this new lesion on my penis. Can you take a look? And those turn out to be Mpox. So unlike during the 2022 outbreak when people are actively seeking us out, now these lesions can be so minor and so painless that they're not even bringing them to care, and they're only mentioning them because they're coming into care otherwise. And so we really need to counsel people that when they have these lesions, they want to come in and get tested. Because we're seeing single genital ulcers or single or one or two lesions, I want to sort of remind people about our single ulcer differential diagnosis. Mpox is one thing, but so is primary syphilis, herpes and HSV, LGV and chancroid. And as Kelly said at the beginning, I've seen a lot of cases, probably over 300 or 400 cases of Mpox since the start of the outbreak. I feel like I'm an expert in visual diagnosis, and even I am constantly fooled between these diagnoses. And so really encourage people to send multiple tests at the same time, not to anchor on one diagnosis and test sequentially, really try to send testing all up front to help make a better diagnosis. To wrap up the presentation section, the presentation can be highly variable. We really need a high index of suspicion, especially after vaccination or prior infection, when it can look much more mild. Immunocompromised patients have the potential for severe necrotizing disease and high rates of morbidity and mortality. Pediatric patients did not have notably worse outcomes, but worse outcomes in pregnancy were seen. And most patients recover, but many with some long-term sequelae. And we want to do everything we can to prevent infection in the first place. The next section is on diagnostics. And, testing was really scaled up very quickly during the course of this outbreak. And we learned quickly that you could diagnose Mpox from many sites: seminal fluid, rectal swabs, urethral swabs, respiratory secretions, and blood. But really the best site to make the diagnosis are skin swabs. And the reason for that is that skin swabs have the highest viral loads and persist the longest. And so really your best site for making this diagnosis is PCR lesion from a skin swab, which conveniently enough is the only thing that's currently FDA approved. So PCR from lesional swabs are available at most local labs, commercial labs, and public health labs. And there's even a home test kit approval through one of the commercial lab companies. When testing for Mpox, it's important to remember the proper PPE. The current recommendations for PPE include a gown, gloves, eye protection, and an N95 respirator. And we should be putting that on before we enter the room in which people are in. In terms of how to test for Mpox, again, we want to put on our appropriate PPE. We want to prepare specimen collection supplies for all co-infections or differential testing. Remember, we want to test not just for Mpox, especially nowadays. We also want to test for things like HSV, VZV, syphilis, and others. And so if we need different tubes or additional tubes, we want to make sure that's all prepared before we go into the room. We want to complete a physical exam of all skin, oral, genital, and perianal areas because it can help us narrow down our differential and also identify other lesions we might want to test. When testing for Mpox, we want to swab the lesion vigorously with a sterile synthetic swab. We don't want to unroof or aspirate. That's very early on in the outbreak, how many healthcare providers became exposed. And so there's no need to unroof or aspirate, and also not to clean the site before swabbing. Ideally, we want to get 2 specimens from different lesions that are sort of in different locations and maybe different in appearance and put them in separate tubes. You may, depending on your lab, also need separate tubes for HSV, VZV, and any other testing you want to perform from a skin swab. You'll then label, store, and transport the specimen per designated lab instructions. Some things to think about again, if testing for Mpox, we're seeing high rates of co-infection. So consider co-infection testing, including HIV, syphilis, gonorrhea, chlamydia, and HSV. I've said this a bunch of times, but testing is absolutely appropriate for people who are previously vaccinated or had previous Mpox infection if they have concerning lesions. As Dr. Tang pointed out, we have a small number of reinfections, and we do have cases post-vaccination as well that are less severe. And really have a low threshold for Mpox testing if any STI is on your differential diagnosis. In terms of diagnostics, clade 1 versus clade 2, I apologize for the typo there. So the lab tests vary. Some of them have an orthopox virus only target, which will be positive in clade 1 or clade 2. So it'll just tell you that it's positive for an orthopox virus. Other tests will have an orthopox virus and a clade 2 target. You want to think about clade-specific testing when someone's a returning traveler from somewhere where clade 1 may be endemic. And also in cases where you're orthopox positive, clade 2 negative, because that really does suggest the possibility of a clade 1 infection. The last section I want to cover today is treatment of Mpox. And the first thing I want to cover is that there's really 3 things we think about. We think about supportive care, optimizing the immune system, and medical countermeasures. First is supportive care. And remember, most patients fully recover. So what we're trying to do is support them in that process. That means helping them address pain control, helping keep the lesions clean and from getting infected. In terms of pain control, things like, especially for bronchitis and genital lesions, things like sitz baths, stool softeners, wound care, topical gels, and even in some severe cases, opioids have all been used to help people make it through the very early, especially the very early painful process. For patients with genital lesions, really helping them keep them clean and dry to prevent infection is really important as well. The next step is to optimize the immune system if we need to. That may include things like restarting antiretroviral therapy for people who've been off therapy for a while. Again, as we saw from some of the earlier studies, people with low CD4 counts can have ongoing viral replication that won't stop unless we get their immune system to help. If there are people who are on immunosuppressants, we want to reduce immunosuppression as much as tolerated. And we want to avoid immunosuppressives if we can. Again, immune optimization really is the most important part of this process. The last thing is medical countermeasures. And this is really things that we can give people that we hope will alter the progression of the virus, but none of these we know work. In terms of medical countermeasures, we have things like antibody therapy with VIGIV, which I will say already is on shortage and may not be available. And we have antiviral medications like tecovirimat, cidofovir, brincidofovir, and trifluridine. One thing I always want to point out is that given similarities in the viral life cycle, there's no expected treatment difference for clade 1 versus clade 2 with any of these medical countermeasures. So we'll spend the most amount of our time on tecovirimat because that's the drug that everyone reads for in 2022 and the one that people ask me about most commonly. Prior to 2022, we actually had very limited information on tecovirimat. We knew that it targeted the F13L protein, which is essential for forming the viral envelope and allowing the virus to exit infected cells. We know that pathway is highly conserved across orthopox viruses. So even though it was developed for smallpox, it should work the same in Mpox, vaccinia, cowpox, variola, and any other orthopox virus. And the drug was actually approved for smallpox via the animal rule. That means that efficacy was demonstrated entirely in animal models, and human data before this outbreak was really limited to a safety study in 359 healthy volunteers. There was no randomized control trial on efficacy in humans before this outbreak. Despite that, tecovirimat was available through an EA-IND, and it was used a lot. In just 2022 alone, more than 7,000 patients received tecovirimat under the Expanded Access Program, and outcome forms were returned to CDC for about 23% of those patients. The most common reasons patients received treatment were sensitive anatomical areas like the penis and rectum, as well as significant pain. There were 223 severe adverse events, the majority not attributed to the drug itself. Those 40 deaths were more attributed to the virus itself in immunocompromised individuals than the drug. Most of the adverse events that were attributed to the drug, like headache, nausea, vomiting, and elevated LFTs, were fairly mild. We then began to get some observational data about whether or not tecovirimat worked. We had a couple studies that said yes, a couple studies that said no, but these were all retrospective studies that were not randomized and not prospective. Ultimately, randomized control trial data showed that tecovirimat did not provide a meaningful clinical benefit for Mpox. In the POM-007 trial in the DRC looking at clade 1 disease, there was no significant difference in lesion resolution compared to placebo. The STOMP trial, which is the one I was involved with in the US, Central America, and Asia, in clade 2 Mpox, found no difference in time to clinical resolution and no difference in time-weighted change in pain. And the UNITY trial in Europe likewise showed no effect on lesion resolution. So across both clades 1 and 2 in 3 major randomized controlled trials, monotherapy with tecovirimat did not improve outcomes. One other thing I do want to highlight before I leave this slide, though, is that we did learn something from POM-007 that I think is important. When the outbreak started, we thought the mortality from clade 1 might be as high as 10%. The mortality in POM-007 was 1.7%, which was much lower than background estimates, which really showed that despite tecovirimat not working, providing optimal supportive care may be beneficial for reducing mortality from Mpox. In terms of why tecovirimat did not work, because I know I get this question all the time, there was some looking at dosing in the POM-007 study, and they did not find any difference in time to lesion resolution between participants with concentrations greater than this 169 nanogram per ml cutoff and participants with concentration less, and this is what comes out of the animal modeling. And there's going to be similar data out of STOMP in the future. It's not complete yet, but we again also don't think that dosing was the issue. In terms of resistance in the STOMP virology substudy, which was presented at CROI, tecovirimat did not accelerate clearance of infectious Mpox virus. Only 7 participants developed treatment-emergent resistance, and 6 of them were people with HIV, most with CD4 counts less than 80. And drug-resistant mutations were linked to higher viral loads and slower clinical resolution, but it does not appear that tecovirimat did not work because of pre-existing resistance. So if tecovirimat didn't work, we do need other options. And again, the caveat is we do not have any randomized control data on these other options in Mpox. Vaccinia immunoglobulin is licensed for the treatment of complications due to vaccinia vaccination. There's no proven benefit for Mpox, and it's expensive with limited supply, and we may not have any available right now. But we can think about using it in severe cases where development of a robust antibody response may be impaired, and potentially for prophylaxis when PEP vaccination is contraindicated or not expected to work. The next thing I want to highlight is trifluridine. Trifluridine drops can be considered for patients with ocular Mpox. Again, the data supporting their use is very limited. These are actually FDA approved for herpes infections, but they are believed to have activity against orthopox viruses. And the CDC does currently recommend considering this in cases of ocular involvement, particularly when lesions threaten vision. They are available at most pharmacies, and I would recommend getting ophthalmology involved if possible. The last drugs I want to talk about are cidofovir and brincidofovir. These are both DNA polymerase inhibitors that block viral DNA replication. Cidofovir is FDA approved for CMV retinitis, so it is widely available, but its use is really limited by nephrotoxicity. Brincidofovir is a lipid conjugate of cidofovir. It actually improves its oral bioavailability and reduces nephrotoxicity. It was also approved under the animal rule for smallpox, but in clinical trials for CMV was associated with GI and liver side effects. It's also available through an EA-IND, and they are available for Mpox, but again, without randomized controlled trial data. There is one trial ongoing in Africa currently, the MOSA trial, that's evaluating the safety and efficacy of antiviral treatments for Mpox across West African countries. And the first drug they're evaluating is brincidofovir, and we'll hopefully get more data from this study in the near future. One other thing I want to mention is cidofovir can also be given topically or injectable. We had some mixed experience with it in our site, but this was a case from Emory with a patient with a CD4 count less than 100 who'd failed multiple standard courses of medical countermeasures. They got weekly intralesional injections for 3 weeks that led to this dramatic resolution you can see here. And they remained in remission at 2 months despite not having a significant CD4 count recovery. And so in some cases, especially if lesions are confined to one area of the body, injectable cidofovir may be an option. The last thing I want to mention is combination therapy. When brincidofovir and tecovirimat were tested together, the results showed synergy against orthopox viruses, suggesting that the combined antiviral effect was greater than what either drug could achieve alone. And so combination therapy could be a promising option. And I will say that currently the CDC recommends if you have someone who's immunocompromised with severe disease or at risk of severe disease, that you consider combination therapy with tecovirimat and brincidofovir. And so what do you do in clinical practice? Well, for those with severe disease or at risk of severe disease, where the potential benefits are greater than the risk. Remember, we don't have good randomized controlled data that these drugs are safe and efficacious. So you really want to make sure that the benefits are greater than the risks. We have had patients with low CD4 counts who had just a couple of lesions who we did not think the benefits would be greater than the risks. And the patients understand the risk and are interested in receiving treatment. In those cases, we consider treatment with a combination of tecovirimat, brincidofovir, and maybe VIGIV when available. We also consider intralesional cidofovir when the number of lesions are limited and they're not improving over time. And with that, I'll turn it back over to you guys, and thank you so much.
Thanks so much. I think Dr. Tang has one more part to share. One moment.
Yes, and hopefully I'll go through this briefly so we can get to some questions, but I do want to focus on reporting of clade 1 Mpox in California. You can go next slide. So it's important if you suspect clade 1 Mpox to report this to your local health department or to us at CDPH immediately if clade 1 Mpox is suspected or confirmed, and do not wait for laboratory confirmation and ensure the patient is isolating. This includes any person who has signs or symptoms of Mpox who may have a history of international travel or close contact to an international traveler in the past 21 days prior to symptom onset. So that was close contact to an international travelers, the situation that we had from the first San Francisco case. Also, if there are preliminary Mpox test results that might suggest clade 1 Mpox. So there are some commercial labs out there that only do orthopox virus testing, while some do both orthopox virus testing and specifically clade 2 Mpox virus testing. So if you might have a situation just on the top of row of that table, a person with a positive orthopox virus testing and no clade 2 or Mpox testing that is done. And so that is likely Mpox, but it's not clear what clade it is. If you do have concerns for it being clade 1 based off travel history, for example, then it is important for you to reach out to your local health department who can potentially expedite doing clade-specific testing for you. And we also do that testing at the state. As I mentioned, there are places, commercial labs, including Quest, which I know was mentioned in the Q&A, that does clade 2 testing along with orthopox virus testing. And if you end up getting a result where there's a positive orthopox virus test, but an indeterminate or negative clade 2 Mpox test, that would make it very highly suspicious for clade 1 Mpox, and you should immediately report that to your local health department, or to us if you can't reach your local health department. Next slide. and this is how it might look, like a detected orthopoxvirus PCR test with what looks like a not detected Mpox or monkeypox virus DNA test. So if you have a sort of a situation like that, again, suspect clade 1, notify your local health department immediately. Next slide. In terms of isolation instructions, important to ensure that you're telling your patient with suspect or confirmed Mpox how to isolate at home. As mentioned before, Mpox spreads primarily through close personal and skin-to-skin contact, as well as through contact with contaminated materials, and less commonly through respiratory droplets during intimate or prolonged face-to-face contact. When they do go home, it's important that they avoid close contact with others, including pets, until the rash is fully healed. And that means when all the scabs have fallen off and a fresh layer of skin has formed. And this can take, this is at this point that they're no longer considered contagious, and this can take up to 2 to 4 weeks from symptom onset. They also should ensure to clean and disinfect shared areas in the room. And also, because the virus can survive on linens, clothing, and surfaces like doorknobs and faucets and handles, it's important to disinfect hard surfaces like doorknobs and bathroom fixtures, as well as for laundry, not shaking it out and keeping that in a separate bag, and wash laundry itself in a standard washing machine. And then also just to note that they should also be notifying close contacts, people who may have been exposed while they're infectious, since people who were exposed may benefit from post-exposure prophylaxis, as previously mentioned, and the local health department can help support people with Mpox in doing anonymous notifications. Next slide. So overall, just want to give this a general assessment of sort of what Dr. Zucker and I spoke about today, but really with this, upcoming World Cup, the Pride season, which you're now in, and summer travel that will be increasing, we do expect both clade 1 and clade 2 Mpox cases to increase over the next few months. And so we ask for clinicians to stay vigilant for Mpox and to suspect clade 1 cases, including in people who've been previously vaccinated or have previously been infected when there are clinically compatible symptoms. Again, if there's any discordant test results or someone who has Mpox symptoms who is an international travel or have been a close contact to an international traveler, please report that to your local health department immediately. And really, the best method that we have to prevent Mpox is through vaccination, and that really can help improve patient outcomes and prevent outbreaks. The risk of severe disease and hospitalization are among people who have weakened immune systems, so vaccinate those people who are immunocompromised, including all people with HIV. And just note that there have been still cases that from both clades that have been unvaccinated, meaning that we're not getting people vaccinated before they've been at risk for infection. Next slide. And these are just some resources I just want to highlight. It's something that Dr. Zucker had shared, these clinical job aids through the California Prevention Training Center that I think are really great visuals for clinicians, as well as we have a web page and a website really related to Mpox on the CDPH website that includes much clinical Mpox guidance that can be helpful. I'm going to go to the next slide. And because it's Pride season now, we do have updated information on our LGBTQ plus health page that includes a updated Pride toolkit for 2026, and that can also help event organizers and CBOs educate attendees at different events and for people in their community about HIV, STIs, and Mpox. And we also have an updated resource that we just posted yesterday on safer sex social gatherings and Mpox, which is really helpful for Pride season. This is something that was up at the CDC website for some time over the past few years, but recently taken down, but we reposted it with some updated information that people can use to educate themselves and practice ways to reduce their risk of getting Mpox. So please check that out. Next slide. And I just wanted to highlight that we do have a new provider listserv through the Office of STIs at the HCV that can be a way for folks to provide or to get more recent updates on STIs, Mpox, and hepatitis C from us directly, and I'll put that link in the chat as well. So I think that's my last slide. You can go to the next slide, just a thank you and acknowledgements. And we can, I guess I'll hand it off to you, Kelly, for our Q&A.
Yes, wonderful. Thank you, Dr. Tang and Zucker, for such an informational webinar on Mpox. I really feel like we covered a ton of information. I know there have been a lot of questions. I'm going to put up our CME information. We only have a few minutes remaining, so let me pull up the CME info. 1 second. Okay. I'm gonna leave that alone for now. Email us if you have questions about CME. But okay, questions from the chat. The first question there were a lot of vaccine questions. Understandably, it's a bit of a confusing topic. The first question around vaccines was one of our participants was noting that Dr. Tang, you had shared that 22% of clade 1 and 17% of clade 2 cases were actually double vaccinated, like they had received both doses of the Mpox vaccine. So the question is about breakthrough infections. How much are we seeing these? How does that compare to other vaccine preventable diseases? Open for either of you to discuss.
I can just maybe start, and maybe Dr. Zucker, if you want to add. As I mentioned, the vaccine isn't 100% effective. No vaccine is, and we do expect there to be, breakthrough infections. We are
Also cut out for me for a second. We're having I'm sorry about the sort of difficulties with connection. It cut out for a second. Dr. Tang, are you back?
through infection, but I think, and I don't have the data comparing it to other vaccine preventable diseases, but Dr. Ducker, I don't know if you wanted to add anything to that.
Yeah, no, I agree. I don't have the data on sort of the exact numbers, but it is what we expect. We expect people who are post-vaccination. Vaccination does not necessarily prevent disease. We know that in many other infections, it prevents severe disease. And that's what we do clearly see here, is that patients who are getting vaccinated are having less severe infections, so the vaccine is working as planned.
Great. I'm going to move us along. A couple of folks had questions about vaccination, but specifically in pediatric populations. So I think it is one for both of you, but the questions were around how you approach adolescents who either, have reasons that they would be indicated for the Mpox vaccine or who are asking for the Mpox vaccine. Are you doing this? I know there's like an 18-year-old cutoff per the FDA, but how are you all approaching this? And then, so maybe that question's for you clinically, since you are a pediatrician, Dr. Zucker. And then for Eric Tang on the CDPH side, does CDPH have an opinion on the adolescent vaccinations?
Yeah. So the sort of current recommendations were 18 and up. However, that doesn't mean there aren't people who are adolescents who could benefit from this vaccine. And we have lots of safety data from the 2022 outbreak that suggests that it's safe in all populations, including in children. And so, I work in New York State where I'm sometimes a little spoiled because very early on, they reclassified Mpox as an STI, which gives us the ability to provide testing, treatment, and prevention without parental consent, the same way we would for HIV or any other STI. And so we've been offering Jynneos vaccine to adolescents since the start of the outbreak for us, using the same criteria we would for anyone else, anyone we think might be vulnerable, anybody who's young, sexually active, and in the population who could acquire Mpox. We're trying to encourage them to get vaccinated.
And I'll just add that our California vaccination recommendations do include anyone that may be at risk for Mpox. It doesn't include adults. And so definitely recommend vaccinating people who fall into risk of getting Mpox. And just to also note that the FDA does have emergency authorization to use the Jynneos vaccine in minors. However, it has to be used or administered through subcutaneous administration and not through intradermal administration.
Do you have to do anything special? I'm an adult ID doctor, so I don't see kids. Do you have to do anything special to go through the expanded access FDA process?
No, because it's not expanded access. It's like an EUA. So essentially,
Oh,
they're
okay.
just providing authorization. One of
I
the
see.
challenges can be, though, that because it's not in the ACIP recs currently, sometimes we've had issues with insurances covering it and other things.
Okay.
And it's not through vaccines for children either for that reason as well. So the payment issue is really the only major issue in doing it.
Okay. So it's fine to give. You might have some insurance issues.
That's
Got
right,
it.
exactly.
Thanks. Perfect. Okay. Thanks for clarifying that for me too. Not a pediatrician. Okay. How about I'm going to try to answer our last couple of questions if you all have another minute. And obviously, if you don't, we'll stop, but I'm just going to keep going. How about asymptomatic or undiagnosed Mpox? How prevalent do you think it is? What are your insights there?
I can go. So
Yeah, go
I think
ahead.
it's less prevalent than we think. I didn't have the time to go through everything, but there's a study from Kings County where they actually looked at rectal swabs to see if they could identify cases of asymptomatic Mpox. And they found it was like 1% in their sexual health setting. So fairly uncommon. The other thing is that that's sort of detection of virus. It doesn't actually answer the question about is that person able to transmit at that time. There was a Belgian study from very, very, very early on that I think found three people out of like over 200 that were positive, and two of the three had culturable virus. So I think that it probably happens, but it's probably less common. The Kings County study also suggested that it's more common in people who are vaccinated because they're probably getting sort of a local infection without having all the systemic symptoms due to vaccination. So again, it's still out there. It's still why we're seeing these outbreaks occur occasionally. And the best thing we can do is to make sure we vaccinate all of our vulnerable patients.
Right. Because even though breakthroughs happen occasionally, you're going to have most likely a less severe infection, possibly even like a minimally
That's right.
symptomatic infection. Perfect. Okay, last question. Talking about how Mpox could be everywhere. Transmission in bathhouses. Somebody was asking, what is a bathhouse? What type of bathhouses should we be worried about? And is this a common place for Mpox transmission? So I think it's driving at community. Like, are there spaces in the community where people may be more likely to be exposed that folks should know about? And this will be our last question.
I can start
Go
off
ahead.
answering this question, but so bathhouses are generally spas or saunas, and there are specific bathhouses that are catered towards the LGBTQ community, and often those are spaces in which people may engage in sexual behavior, or you meet partners, have anonymous sex, sometimes in those spaces. And so, given the way that mpox can be spread, it can be a place where of high risk mpox exposure. And since 2022, we have identified these places as places where people have reported attending in their incubation period and getting mpox. So it's a reason why we, in our vaccination recommendations, include if anyone has been to one or anticipates going to one, that they get vaccinated against mpox.
Perfect. Thank you for clarifying that. We are 4 minutes over, so I'm going to call it and let folks go about their days. But thank you, Dr. Zucker, Dr. Tang, for both being here and sharing your expertise with us, and especially to all of you folks who attended today. Hope to see you next time. Bye.